Hi everyone. Like as you know, I just posted the NEET SS previous year questions of around 2020, 2019, 21, etc. But a lot of you wanted the later ones, the 2022, 2023. Although we have them in our app, but they're kind of scattered. They're kind of, like not really put together as papers as 2022, 2023 in our PYQ section. So I wanted to, compile all the questions and do a session, but obviously that would make it a very lengthy session. It has come to I think around 70 to 80 questions. We do have a few more, but we only have the topics, whatever the questions we have properly with options that I'm going to cover. At the same time, obviously, in just one session in an hour or so, it's really difficult to cover 80 questions and their explanations as well, why each question is wrong, where did this come from, what is the topic itself. It's almost impossible because each topic would take at least 5 minutes, so that would take at least something like 8 hours or something. So I'm going to go a little bit quickly. You might feel it a little fast, but always keep a note at your hand so that you note down the question and the answer, because the main motive of this session is that so that you don't get your PYQ direct repeats wrong in the exam that is coming up, right? And also, whoever is seeing this session, if ever they miss out on some question or something, you definitely ping me. I'll send you the question, and this PPT would be ready I think by tomorrow or something, and we can send you the PPT as well. Yeah, so that's not a problem. Like, you don't need to worry about missing any question or something. You can always text me about taking the question or the PPT, whatever is there. So this is how the firstly we'll do 22, then we'll do 23, right? So 22, mainly the focus was a little bit more on pediatric critical care, pediatric emergencies. Cardiology, neonatology had focus as it always is, but the topics, the areas that were covered were a little bit tough. General pediatrics was a little bit easier, and also there were repeated topics that are always there. Repeated topics, as you can see, 22 to 23 also you will see some topic repeats that are there. So always repeat topics are there. Maybe not as much as INISS. Actually, INISS has a little bit more of these repeat topics, but NEET SS also does have. So uncommon, untouched topics a little bit were there, especially in your neonatology, cardiology, genetics. But otherwise, it was okayish. But there was a shift. Like now, it's not so much relevant because now the papers have become clinical. All the papers are clinical only predominantly. But at that point, it was clinical compared to your older papers, right? So many of these questions Aditya and Divya have discussed in the last two papers, last two sessions that were done on the weekend. I'm again trying to compile everything into one, particular module. So I'm not going in depth into the topic. I'm just, compiling them and presenting it to you. Right. So a child was with PSGN comes with nephrotic range proteinuria. There are certain indications for biopsy, and here they are. This was discussed by Aditya also. So the question here was when to do it, right? Maximum at what point to do it, and the answer was 2 weeks, right? So there are various cutoffs. When gross hematuria is there for more than 1 month, then you will do it. If microscopic hematuria, you'll wait for 1 year. If there is something like AKI, something like azotemia, oliguria, then you can wait not more than 2 weeks before going for a biopsy. And here the question was for nephrotic range proteinuria, and that is also for 2 weeks. Persistent proteinuria, that is non-nephrotic range, that is 6 months, right? This was the question. Then you have an infant with irritability, regression of milestones, opistotonic posturing, intermittent fevers, hyperpyrexia, optic atrophy. Looks like some IEM, and here the IEM that is there, especially optic atrophy, is a good clue here. And yeah, so opistotonic posturing, regression of milestones, and optic atrophy, these are good clues for Krabbe's disease. So this is Krabbe's disease, and this is galactocerebroside beta galactosidase. Again, not going much into details. You should know how to kind of zero in on Krabbe's disease and what the exact enzyme is. IL-6 inhibitor, very straightforward. I'm not really sure this is important to in today's context. At that point of time, MSc was a big thing, MISC was a big thing, and that's why it was even more important in 2022. Now also, it has been asked before, and as monoclonal antibodies are coming up, it is important to note IL-6 inhibitor is your tocilizumab. Yeah, true regarding all are true regarding scabies in a child, except so scabies in child we have discussed in our parasitology module in our infectious diseases, there I focused upon this. 5% of permethrin is used. It is not 1% in scabies. In bed lice, you can consider 1% permethrin, but for scabies, S5, this is an important mnemonic. So scabies, 5% permethrin is to be applied and not 1% permethrin. Rest are correct. Obviously, it's an arthropod spread by fomites. Obviously, nodular scabies can be seen in AIDS patient. These are all correct statements. Treatment is 5% permethrin cream. Yeah, so this is about epileptic spasms. So West syndrome, usually the treatment of choice, drug of choice is ACTH, but in tuberous sclerosis, as you can see, this is what we call ash leaf macule. This is shagreen patch. So I'm not really sure what image was given. I think probably ash leaf macule would have been given. So ash leaf macule, kind of, indicator for tuberous sclerosis, and the drug of choice of epileptic spasms or West syndrome in tuberous sclerosis is vigabatrin. Second line is ACTH here. While normally if you ask your West syndrome or your just epileptic spasms, drug of choice will be ACTH. Second line would be vigabatrin. Then you have a severe acute malnutrition child on day 3 developed tachycardia, tachypnea, and hepatomegaly after initial stabilization. So what is happening here? Refeeding syndrome is happening. That is when a malnourished child receives very quick or rapid nutritional rehabilitation after prolonged starvation. When he receives rapid, rehabilitation or stabilization, then the body switches to fat metabolism due to lack of glucose, and when feeding is started instead, then insulin secretion is increased when you give carbohydrates, and then that metabolism changes. So when that metabolism changes, there are shifts of electrolytes, intracellular shift of a lot of electrolytes, especially like potassium, phosphate, magnesium. All of these occur, right? So magnesium, potassium, and phosphate. So all of these go inside the cell. So what happens when something goes inside the cell? The serum levels drop, and main hallmark one here is hypophosphatemia. Obviously they wouldn't have given hypokalemia, hypomagnesemia in the options because that also is right. So the hallmark one is hypophosphatemia. Apart from be going inside, what happens is that is essential for ATP production, right? So all the phosphate is going inside, and that can lead to sudden depletion of energy as well. That can lead to tachypnea, tachycardia, hepatomegaly, generalized weakness. All of this can occur. Hyponatremia, hyperkalemia. Hyperkalemia obviously doesn't occur. Hypokalemia can occur. Hypoglycemia doesn't occur in refeeding, it occurs before refeeding, so that is also wrong, right? So post-drowning CPR, again, no precise answer here. Actually, Nelson, if you look at Nelson exact sentence, it says several hours, right? Best answer, however, if you look at some research articles, etc., it's something like 6 to 8 hours is something that I could find. Best answer, I feel, would definitely be 12 hours here. So, which is correct regarding dyskeratosis congenita? So, dyskeratosis congenita versus Fanconi's anemia is one good, comparative thing. Both present with possible aplastic anemias, but Fanconi's has skeletal dysplasia, while your dyskeratosis congenita will have lacy reticular pigmentation. So, skeletal malformation is not there, not seen in your dyskeratosis congenita. This will have nail dysplasias, leukoplakias, skin pigmentation changes, tooth abnormalities, all of that, but skeletal malformation is not seen. Lenticular opacity. So again, this is also picked up from Nelson only. So lens opacities of various types may occur in chromosomal anomalies of 13, 18, and 21, Down syndrome, Patau syndrome, Edward syndrome, all of this. But trisomy 5 is not usually associated with your lenticular opacities. So this is again important. This is quite a kind of trick question. It's a difficult question, I would say, because doxycycline allergy and doxycycline resistance are two different things, right? So when there is doxycycline resistance, the best answer is actually azithromycin, but here it is doxycycline allergy. So doxycycline allergy, when it is there, then the best answer is chloramphenicol, right? So this is a very important question, and I think it was discussed a lot also. Chloramphenicol is the right answer. It's not azithromycin. So heparin basically exerts via your heparin antithrombin 3 complex. So that will again go and inactivate thrombin, that is factor 2A, and 2 and factor 10. It will inactivate via antithrombin 3. So that is, it's more or less straightforward question. If you read hemat and if you read HIT, all of that you would obviously read about heparin, right? So it's a more or less a straightforward question only. Factor 2, factor 10 via antithrombin 3. It will inhibit and lead to anticoagulation. Then a child presents with gross hematuria and sensory neural hearing loss. This is more or less straightforward only because there is brother also is given X-linked indicator is also given similar history. So this is what is Alport syndrome. So just to remember, can't see, can't be, can't hear a bee. That is just to remember, can't see means there are changes in your eye, basically retinopathy, lenticonus, anterior lenticonus, all of that can occur. Can't be in the sense some kidney changes like glomerulonephritis. SNHL, can't hear a bee, just to remember. So all of this occurs basically splitting and irregular thinning and thickening of basement membrane occurs here. Immunoglobulin staining is usually negative, but what is important in your histopathological appearance is your basket weave appearance. That is important. So which is true regarding dyslexia? Again, to be very frank, this was discussed by Divya. I am not really sure regarding the why the other options are, I'm not really sure about these options, to be very honest. But pretty much sure that all cases do not have a heritable basis seems correct, right? Obviously all cases having a heritable basis doesn't seem correct. Obviously whenever you have options like all or none, extreme options, they're usually wrong. But here it says all cases do not have, so seems correct. Otherwise also functional MRI is not usually investigation of choice, is more like a high level test that is used in research. Reevaluation of diagnosis required after 6 months of initial diagnosis. I don't think it's there any guidelines are there like that. Fluency improves better than accuracy with treatment. I'm not sure, but D is the right answer here. Which among the following is the most common symptom in Sjogren's? So if you look at adults, it's more of your oral sicca, ocular sicca, etc. While in your pediatric age group, even if you see the classification criteria, diagnostic criteria also, the first thing that is written is recurrent peritonitis. There are a lot of children that come with benign recurrent peritonitis, and Sjogren's has to be ruled out because children, especially not adults, can present just with peritonitis only. Sjogren's only with peritonitis. So that is one very important, atypicality, or you can say typicality of Sjogren's syndrome in children. So recurrent peritonitis is the option here. But which is not involved in polyarthritis nodosa. So polyarthritis nodosa we did discuss a little bit in our main video. So one thing I told was PAN, pulmonary artery, not involved. So why is this so important? Because it's asked right, left, and center in your NEET PG questions, in your INI-CET questions. Now you see NEET SS Pediatrics questions also asking the same thing. So pulmonary artery is not involved, and another important thing is glomerulonephritis doesn't occur. So these two are very important concepts in your polyarthritis nodosa. So artery not involved. Sorry. So artery not involved is your pulmonary artery. Then you have most cases, again, this was discussed by Aditya, 40% are transient, right? 40% are transient and self-resolving. This was discussed by Aditya a few days back itself. Then Bartter syndrome also we had discussed. So Bartter syndrome, similar to your loop diuretic, right? So just how I remember is Bartter, Gentleman. Bartter behaves like loop diuretic, Gentleman behaves like your thiazide diuretic. So loop loses calcium, so obviously hypercalciuria and possible nephrocalcinosis can also occur in your Bartter syndrome. So yeah, this is a good table to differentiate it. Early life, Bartter syndrome, dysmorphism may be present in your Bartter syndrome, SNHL dysmorphism, all of this can be present. Calcium is a direct, something like loop loses calcium. So direct, this is the easiest one to remember, to be honest. SNHL dysmorphism, you have to remember that it occurs in Bartter. Magnesium, again, thiazides have a major role in magnesium changes. Thiazide, if you remember, they cause hypomagnesemia a lot compared to your loop diuretics, which don't change magnesium much. Renal prostaglandin production, this is increased in Bartter, while Gentleman is not much affected. And treatment is kind of, indomethacin that you use in Bartter syndrome. That is again an important one, because as you can see, prostaglandin production is increased, right? So to counter that, you use NSAIDs like indomethacin, while Gentleman, you just supplement whatever is getting lost, right? So this is a very classic 3 Hz spike and wave pattern that you see in your absence seizure. So what is the drug of choice in your absence seizure? Ethosuximide, right? But at the same time, you would know carbamazepine, oxcarbamazepine, all of these are contraindicated in your absence and myoclonic seizures. They can be used, carbamazepine especially can be used in your SSPE, post-measles sequelae SSPE. Myoclonic seizures, it can be used, but in general, it is contraindicated. It can worsen your absence and your myoclonic seizures. Liver transplant is indicated in which? So the answer, this was discussed by Divya again. there are multiple reasons for this. The best answer is tyrosinemia. So here again, liver nodules are also there in tyrosinemic patients. So that also it's difficult to differentiate them. So for patients with severe liver failure not responding to nitisinone, liver transplant is an effective therapy which can also alleviate the risk of these malignant nodules leading to hepatocellular carcinoma. Pulsus paradoxus, this we've been reading through our MBBS. It is chronic constrictive pericarditis. We read Kussmaul sign, pulsus paradoxus, square root sign in your JVP. If you would remember, these are classic signs that we see in our cardiac clinical examination. So there are multiple causes, not just pericarditis, chronic calcific chronic constrictive pericarditis. There are other causes also, like your acute severe asthma, cardiac tamponade can also cause pulsus paradoxus, your tension pneumothorax, pulmonary embolism, severe shock can also cause pulsus paradoxus. All of these causes are there, but among endocarditis, pericarditis is definitely best answer is your pericarditis. True regarding renal morphogenesis, again, I'm not really except this one. I think this is the only one I actually know that it is true. And obviously glomerular base membrane, it has these lamina rara, interna, externa, media. These are only 3 layers, so this is definitely wrong. 6 layers. This is something that supposedly they changed from your older edition, Nelson, to your newer edition. Older edition, it was given 36 to 40 weeks, but then the newer edition, it is given as 34 to 36 weeks. And it is said that functional maturation continues till 2 years into the first decade, and it's not the nephron growth, right? So the first one is also wrong. Postnatal attrition doesn't occur, right? If postnatal attrition keeps occurring, nephron loss keeps occurring, then that is doesn't make any sense. Obviously nephron will stay constant, otherwise it will be CKD, and also this is also wrong. So B is a correct option. This is the exact number that is given in your Nelson. So somebody obviously took that Nelson chapter and made these questions, right? So 0.2 to 1.8 million per nephron per kidney. The nephron number per kidney is a right option. Then liver transplant. So liver transplant for EHBA, biliary atresia, or any liver transplant for that matter, one of the most common major complications is your hepatic artery thrombosis. So hepatic artery thrombosis is your complications by default. Also, it's the major complication, and also that is the one that can further lead to biliary stricture and biliary sludge. All of that it can lead to, and that can lead to sepsis. So that's why the main etiology or main complication of your post liver transplant complication is your hepatic artery thrombosis. Then this was discussed by Aditya. Yeah, so this was discussed by Aditya. There are multiple reasons that these are embryonal brain tumor is asked. So ependymoma and your astrocytoma, these are not embryonal brain tumors at all. Then chromosome 17 is asked. We have been reading through our Robin's days. Retinoblastoma is chromosome 13q. So medulloblastoma is associated with chromosome 17, and that is the right answer. Then this is again pretty much one of the more simpler questions of this lot. So bone age is equal. First of all, it's normal growth velocity. So these both you can remove because they don't have normal growth velocity. They have slower growth velocities. When bone age is equal to chronological age, that means constitutional delay is not there. Constitutional delay will delay the bone age compared to chronological age. Familial short stature will not delay the bone age. So when it is equal, then the best answer is your familial short stature. Which this is very simple one liner. If you've read this, you know this. Again, this is a very common MCQ since our NEET PG days. So pseudo appendicitis is caused by Yersinia enterocolectica, right? So Yersinia is the correct answer. So a mother with SLE delivered a baby. This is slightly confusing because usually what we read through our neonatal lupus and what we read through our guidelines, etc., is what to do before the baby is born. So here, after baby is born is given, but actually if you just remember the before the baby part only, that also you can use after the baby is born also. Options are also very similar, so that you don't need to, luckily they have not given an option that no need to do anything or just observe. If they gave an option like that, then it would have been confusing, but there's no option like that. All of these are proper interventions. So among those interventions, delivered a baby, will you do echo? Like that's nothing related to echo, right? Echo, you just screen to see what the heart health is while the baby is antenatal, right? So here second heart block is already there. No need to do an echo here. What is the next step is you actually start dexamethasone. So there's a whole flow chart. Even if you go through that flow chart, obviously I'm not discussing all the whole flow chart here. Start IVIG is definitely wrong. We don't have enough evidence for that. Plasmapheresis is definitely wrong. So start dexamethasone is the best answer here. So a child aged 12 years had proximal muscle weakness, positive Gowers, and most important one here was that CPK was in normal limits. So firstly, you can exclude other options where you have, for example, BMD, etc. You have CPK which is elevated, while classically CPK is normal in your Nemaline rod congenital myopathy, and that is the best answer here. Benign innocent murmur. So benign innocent murmur is usually systolic. So diastolic rumbling murmur is not correct. Then radiation usually doesn't occur. It's usually seen in 3 to 7 years of age group. So this is also wrong. Radiation doesn't occur and it is usually systolic. And also the changes occurs with respiration. The change occurs with posture. The change occurs. For example, when the child sits or stands up, etc., then the murmur is terminated. So intensity definitely changes with position. So that is the correct option here. Again, I'm not really sure why they asked this question. Very obviously, it's an important space. Subclavial hematoma. If there is a hematoma that forms there can be a possible compression of your increased ICP, etc. That can occur, but I'm not sure why they want to know exact 1 centimeter increase. They basically want to know the volume there, right? So how much volume is there in that subclavial space? So there 1 centimeter is 260 ml. Again, you just have to remember this because it's a previous year question. Yeah, so that is an important fact. Clinical features appear earlier in successive generations. So these are all genetic, terms. Here the answer is obviously anticipation. That is the next generation. It will be more severe in terms of earlier presentation will occur. That is what is called anticipation. Anticipation, as the word itself says, anticipation is you want it, early, right? So you get that early. That is what is anticipation. Penetrance means how the phenotype is manifesting. For example, you have a specific genotype. Is the phenotype coming to you or not? For example, 100 patients are there having a specific genotype. The percentage, if 90 of them are developing the disease, then it is good penetrance. If only 10% are developing that the disease while having the genotype, then it is less penetrance. That is what is penetrance. Pleiotropy is when a single gene controls multiple unrelated traits in the body. That is what is pleiotropy. In mosaicism, we know it occurs in Down syndrome, multiple diseases where a single body can have 2 or more different genetic cell populations. That is what's called mosaicism. So the correct answer here is your genetic anticipation. What is the most common type of genetic mutation producing diseases? This is a very generic question. The answer is missense or nonsense mutation. This is also directly from your Nelson. So frame shift, silent mutation, obviously it doesn't produce disease itself. Small deletion or insertion, missense, maybe here the confusion might be there. The best answer is missense or nonsense mutations. Non-penetration, I already told you that mutation does not result in phenotype despite having the genotype. As I told you, if 10 people are developing the disease while having the genotype, that means that 90% is non-penetrance. That is what is mean. So B is the correct answer here. LAD2, what is the most common blood group abnormalities? Again, if you have read LAD to any extent in yeah, we've even discussed this in our PIDs in our pediatric rheumatology. So Bombay blood group is the best answer here. Cyclic vomiting syndrome. So here family history of migraine is seen. Episodes, again, this was discussed by Divya also, so I'm not going into again. It's more common in females than males. That is wrong. Episodes of vomiting last for 12 to 24 hours, do not respond to hydration, wrong. Usually persist lifelong without improvement, wrong. Family history of migraine is seen in 30 to 40% is a correct statement. Right, so you can pause and look at this even if you want to study regarding cyclical vomiting syndrome, because I think it's a slightly less touched upon topic, but a important topic nonetheless. So tumor lysis syndrome, obviously there will be more lysis, so there will be more hyperkalemia, there will be more hyperuricemia because of the cell lysis, and there will be hyperphosphatemia because all of these come out from the cell, right? But whenever there is hyperphosphatemia in the serum, those phosphate go and quench calcium, right? So hypocalcemia occurs and not hypercalcemia. So not seen is asked, and hypercalcemia is the correct option. So that was with respect to NEET SS 2022. I think we did around 45 questions or so. We have few more ones. you obviously know, right? So we do not have so many people giving the NEET SS paper and then helping us recall them. Obviously, this time I think we'll have a lot more recalls. 2022, I think we have around 70, 80, including everything. These were the ones which we were sure about the options. So that was what we were discussing. Rest of them we have mentioned in our classes here and there, and we did PYQs also here and there we've done. I'll try to compile it, and again, obviously, I'll try my best to do it before the exam. But even if it's not there, these questions at least definitely you go and be confident with. Right. So that was about NEET SS 2022. 2023, the more focus, a little bit more focus was on pediatric neurology, nephrology. As usual, oncology was simpler than before. Neonatology was there as usual, and there was more focus as well. General pediatrics was easier than previous sessions. Slightly less common topics like strabismus, capnography, these were asked here. Again, as you see, we know that strabismus, capnography have been asked, but we don't know the exact question, right? So that's why this is one example where I would say do go through capnography. I think I'll post one pager about capnography also. That also you can go through. Strabismus was also asked, but we don't know exactly what options were there, right? So that also we'll try to get this time. At least we'll get more than 100 questions at least, right? So yeah, this was actually NEET SS 2023. I do remember it was a difficult paper. Genetics was asked a lot. Clinical based questions were asked a lot. Your simpler milestones, etc., were also touched upon. I think one of the question is there, which we'll be discussing. Critical care in 2022, it was more. 2023, it was less. Drug related questions have been coming. For example, tocilizumab, we saw that had come in 2022. 2023, they were lesser, but again, we don't know what will come here. Right, so short stature, dysmorphic faces, short limbs, low baseline IGF, but normal GH stimulation test. That is, there is some abnormality with respect to the receptor, and that's why Laren syndrome is the correct answer here. Down syndrome is usually caused by which what type of cell division here? It's usually maternal abnormality that occurs. Maternal meiotic non-disjunction occurs of course chromosome 21. So this is what happens in your 95% of the cases. There are other mosaicism etc also that occurs, but it is meiotic, maternal meiotic non-disjunction, that is most common. So Down syndrome with bradyarrhythmia, clinical question was asked. Heart rate was 46. ECG shows heart block. Query 2:1 ratio heart block was there. Previous heart surgery, hypothyroidism on eltroxin. So this was basically I'm not really sure what was being asked, but obviously you're looking at some congenital heart disease where there is heart block. So I think it's in 2:1 heart block. It is especially if it is symptomatic, if the patient is symptomatic, definitely will consider permanent pacemaker. Again, I'm not really sure what the question was. Temporary pacemaker, unstable patients with acute symptoms only we usually use, and in ICU, long-term solution is better to give a permanent pacemaker. So here there's no indication of acute setting or unstable setting, nothing like that is there. So better, I would suggest that permanent pacemaker is a better option than a temporary pacemaker. So 5-year-old presents with steatorrhea, failure to thrive, ataxia, retinitis pigmentosa. These are acanthocytosis. These are very easy clues actually. Decrease level of cholesterol, triglyceride, absent serum beta lipoprotein. So it's directly a beta lipoproteinemia, right? So that's a very, very straightforward question. Inherited with mostly autosomal dominant. So I would suggest you remember again, this is a retinoblastoma, but do remember these mnemonics. You can take a screenshot or you can pause and write down for autosomal dominant and autosomal recessive. These are asked repeatedly, especially NEET SS 2023. I think 2 questions were there. Autosomal recessive was also there, dominant was also there, and there's a history of them asking autosomal dominant, autosomal recessive, and they usually repeat these important diseases only. It's not that they go into very weird genetic disease etc. These important diseases only, autosomal dominant, autosomal recessive, have to be remembered. So these are for autosomal dominant, and this was for autosomal recessive, ataxia-telangiectasia. Especially your primary immunodeficiencies, that they will definitely focus upon your inheritance pattern. That is also important. So this is for autosomal recessive. So these are also important diseases which you can pause and you can remember just before the exam. I think this is one topic where just the morning of the exam or maybe the previous day you should read this. Incorrect chromosomal pattern. So MRKH46XY is definitely wrong. So MRKH is seen in female, right? Just like the incomplete or abnormal development of the uterus, and that upper two-third of vagina is abnormally developed in your MRKH syndrome. Ovarian function is normal, secondary sexual characters are normal, all of that is normal. So that is MRKH syndrome. Swire is usually a male, that is genetically male, that there is disorder of sexual differentiation there. So Swire is XY, that is correct. Klinefelter Turner is easier ones. So MRKH is 46XO and not XY. This I think was a little bit difficult question actually. I would have expected if they're giving like this some abnormal fingers and congenital heart defect, then I would think about whole torum. But actually, the here answer is Ellis Van Creveld syndrome, because here whole torum will have absent thumb, right? So the radial defects, thumb loss, absent thumb, etc. will occur. Here there is polydactyly, post-axial polydactyly occurs here. Short limbs can occur, but polydactyly occurs. It's what is called chondro ectodermal dysplasia is what occurs in your EVC or Ellis Van Creveld syndrome. Apart from that, ASD is the most common one. Yes, so ASD also they have given single atrium is usually seen, and also there are dental anomalies also. So it's actually a classic case of your Ellis Van Creveld syndrome. Holoprosencephaly, again, we have discussed this actually in our pediatric endocrinology, and I think we have discussed in one of the elites also. This pediatric pituitary gene syndromes, these are being asked left, right, and center. NEET SS, INSS general also they have asked. In pediatric endo, obviously they are highly focused upon. Even in NEET SS, these pediatric pituitary and even to an extent thyroid genetic syndromes they are being asked. Genes, genetic syndromes, etc. are being asked. This is one example, holoprosencephaly. SHH pathway repeatedly asked in INSS, and NEET SS also it has been asked. So this is more or less straightforward. Only when you hear this in pediatrics, there is only one answer that you're thinking of, that is Menkes syndrome. They may give you an you know image also next time, who knows. So Menkes syndrome you always read along with your Wilson's, right? So that also it's an important one. Here you have low serum copper, ceruloplasmin levels, etc. So best answer here is your Menkes disease. Milestone question, again, not going into the details here. Tower of 4 blocks, horizontal line, but no circular stroke. Not going into the whole chart to discuss that. Here the answer is 18 months. So again, before going to the exam, just one day before, I would suggest go through the developmental milestones definitely. So this was with the route via which nusinersen would be administered. So it's an antisense oligonucleotide that is usually a new drug. New now it's I think pretty old, like not a very new drug used for spinal muscle atrophy. It's used in all types of spinal muscle atrophies, and it works via the process or the concept of axon skipping. So this also they may ask you, but so antisense oligonucleotide and axon skipping and intrathecal route. So these three facts definitely remember about nusinersen. Obviously, it's used in all types of SMA spinal muscle atrophy. 9-year-old boy presents with fever, sore throat, neck pain, swelling, blood cultures grow Fusi-bacterium. So whenever you hear Fusi-bacterium and you hear septic emboli, so when you hear oropharyngeal infection, septic emboli, septic thrombophlebitis of internal jugular vein, when these three things are heard, you always think about Lemierre syndrome. So what are the three things? Fusobacterium infection, septic emboli, and internal jugular vein thrombophlebitis. So when these three things are there, always think about your Lemierre syndrome. Then so this also you can kind of pause and look at it. So IE would be caused by Staph aureus, strep, etc. Here Janeway lesions, Osler nodes there will be there. Retropharyngeal abscess, that will be different. You'll be having a lot of neck stiffness, fever, sore throat, etc. Here also there is a recent throat infection that is there, but here septic emboli is the clincher, and IJV thrombosis is also a clincher. So this is again something that is weird. SSRI, when the mother takes, then the neonate develops what is a neonatal adaptation syndrome. So transient irritability, poor feeding, jitteriness, mild respiratory distress, all of this occur during the initial few days of life. So again, coming to the differences, when maternal SSRI use is there, neonatal adaptation syndrome. When maternal opioid use is there, the neonatal abstinence syndrome. So I feel this thing can be tested upon again, because options also they've given opioid use, SSRI use. So in your opioid one, that is your neonatal abstinence syndrome, you have more of irritability, you have diarrhea, hypertonia, sneezing, etc. While in your neonatal adaptation syndrome, via your metal SSRI use, you have poor feeding irritability is there, but jitteriness, tremors, transient respiratory distress, all of that occurs. Sepsis is completely different. They'll be can present like anything, obviously seizures, hypotonia, poor feeding, fever, hypothermia, anything it can present as. Hypoglycemia also is a good mimic for neonatal adaptation syndrome, but that also has got nothing to do with your main thing, that is your maternal SSRI used during pregnancy. That is a clincher for neonatal adaptation syndrome. So this is important. This is again somewhat of a difficult question. One of the difficult questions there, I think we saw was the chloramphenicol one, where doxy allergy use chloramphenicol, doxy resistance use azithromycin. Similarly, here also Q fever, right? Coxiella burnetii Q fever is caused if it is uncomplicated, that's there is no, it's just fever, it's just mild ricket, like, your infection, mild infection without endocarditis, that is called uncomplicated Q fever, then you go for doxycycline. But if there is endocarditis, it's complicated, then you go for doxycycline along with hydroxychloroquine. There are few concepts also. HCQ actually helps in the doxycycline to enter into the coxiella. There are concepts like that. Even if you don't remember all that, basically doxycycline plus HCQ is given for Coxiella burnetii endocarditis. Rapid onset obesity, this we have discussed. Obesity syndromes multiple times asked. We have discussed in our ELITE tests, we have discussed in our main video banks, TND, everywhere. So this is rapid onset obesity with skin picking disorders. This is Prader-Willi syndrome. This also, as I told you, growth hormone deficiencies, genetic abnormalities. This I think same direct question we had discussed in ELITE. I don't know. Yeah, obviously it would have been after the NEET SS 2023, but definitely it was not picked up from as a PYQ or something. So this question is asked repeatedly, even in your previous questions, previous years also this has been asked. So that's why maybe I put it. So this is basically GH deficiency, single central incisor, especially in your SSH, that is sonic hedgehog gene defects. There you see with GH deficiency, single central incisor, that is a classic example. Casal necklace, MBBS question or maybe even 12th class question, that is seen in niacin deficiency. Mutation responsible for acrodermatitis enteropathica. Again, I'm not really sure how important this is, because I might not even answered this when I would be reading. So it's a difficult question, but the answer is SLC39A4 gene defect. This I think we had discussed this last on Sunday. Selenium deficiency. So this is selenium deficiency is also called Keshan disease. So Keshan disease is associated with your cardiomyopathy. So cardiomyopathy is the correct answer here. So which toxicity? This is not your deficiency. Which toxicity is associated with increased bleeding risk? So vitamin E toxicity can cause increased bleeding risk, especially if a patient is already on warfarin or heparin or low molecular weight heparin surfactants injections or something. Vitamin E toxicity can inhibit vitamin K dependent clotting properties, leading to increased PTINR, increased risk of hemorrhage, increased toxicity of warfarin. All of this can occur, especially hemorrhagic stroke risks have been seen to be increased in your vitamin E toxicity. So this CHF-like features in refeeding syndrome. So you see repeated topics, right? Refeeding syndrome had come there also. And again, CHF-like features, we discussed about hypomagnesemia, hypophosphatemia, etc. But CHF-like features occurs. Mainly the classic one is hypophosphatemia. That is important. So refeeding syndrome occurs when there is, so when you have a SAM patient, when you start, then electrolyte shifts occur, leading to cardiac dysfunction, muscle weakness, respiratory abnormalities, neurological symptoms, all of this. Thymic is completely different. That definition is different. Hypomagnesemia will not lead to CHF, it will lead to neuromuscular issues, but not CHF-like symptoms. Potassium also will occur, but it will cause arrhythmias, etc., but not your primary cause of CHF-like features. So this is how you can remember PhosK-Mg. That is your main hypo manifestations, that is your main electrolyte imbalances that occur in your refeeding syndrome, but CHF-like features mainly because of your phosphate loss. Again, this is TAM, transient abnormal myelopiosis. This is something like an abnormal state that occurs in your Down syndrome. Many times it is abnormal myeloid state that occurs in your Down syndrome. Many times it is self-limiting, self-resolving, won't even require chemotherapy. Only severe ones require chemotherapy, because your 20 to 30 patients, 30% patients of your TAM will become AMKL, megakaryocytic leukemia. Acute megakaryocytic leukemia can develop in 20 to 30% within the few years of life. That is, they usually they will be self-limiting, but they do have a higher risk of developing leukemia later. So it's not completely a benign condition. So that is what you have to remember. So less than 1% have TAM, that is wrong. Around 10 to 30% of Down syndrome patients will have TAM. All require intensive chemotherapy, that is wrong. As I told you, most of the cases of TAM are self-limiting. Those with TAM have less risk of developing leukemia later. Less is again a very weird term. It's 20 to 30% here also, so less is not right. Kata1 mutation is seen in blasts of TAM, that is correct. So this is the correct option. EEG that demonstrates electrocerebral silence. So this is something that we have discussed in detail, brain that we have discussed in detail in a pediatric critical care. There are a lot of cutoffs. We discussed a lot of time cutoffs there. For EEG, the cutoff is 30 minutes, which you should remember. Then, yeah, so this also we have discussed, I think, same questions we have discussed in two elites. Both elites have put the same question: epiglottitis, laryngotracheobronchitis, croup, bronchiolitis. All of this has been asked repeatedly in your previous NEET SS. This is again very, very easy. Actually, thumb sign they have given, tripod position they have given, appears toxic, everything is given. So, especially in your infectious disease, either they're giving pharmacology based questions which are a little bit tough, or they're giving clinical questions which are more or less easy only. So infectious disease, many students have been asking how to read, etc. So I don't think you should focus a lot on your infectious disease. Do focus on pharmacology, whether you can get hold of some, charts for drug of choice, or even if you go to your old NEET PG preparation, pharmacology, antimicrobials, when you would have those materials, whatever pharmacology material you would have, which you would have read, that is, they are sufficient for your antimicrobials part. And main diseases like diphtheria, TB, HIV, all of that you should focus upon. COVID, I think they've stopped asking. So again, that was also one doubt. So COVID, I don't think they'll be asking. So this again, Alport syndrome. As you saw, Alport syndrome was asked in the 2022. Again, Alport syndrome has come here. So I didn't mention this there. Call for A5 gene, type 4 collagen, alpha 5 chain of type 4 collagen, and this is for the X-linked X-linked type of Alport. The autosomal recessive has called 3A3, etc. Other things are there. They are not. They are lesser prevalent. The main X-linked dominant form of Alport will have call for A5 gene mutation. So this is basically which of the following is incorrect, right? So this is basically a coloboma that is seen in inferior. So this is what is called a keyhole appearance. So mostly located superiorly is wrong. As you can see here itself, it's located inferiorly. Does not involve the fundus and optic nerve. Definitely wrong. A lot can, many of your colobomas can involve fundus and optic nerve, and they can be associated with your systemic changes as well. For example, we know charge syndrome that is associated with your thymic anomalies and genital anomalies, your mental intellectual disabilities, eye colobomas, all of that, analectasia, etc., heart defects. So there also, that can also be seen with colobomas. So definitely no need of further evaluation is wrong, because further evaluation is needed to rule out all of this. Frequently transmitted as autosomal dominant trait. This is the correct option. Even if you don't know this, because there was an image, you can make out. And if you know that this is something that can get complicated, even if you know that much, even if you don't know autosomal dominant versus recessive, you can get this question right. I understand this is a difficult question, but yeah, you can get that question right. So 18-month-old child, Sogia, systemic onset JIA, 1 month ago, remission, today presents with high spiking fever, lymphadenopathy, hepatosplenomegaly. The classic part here is the last thing that is given, that is low ESR. So whenever there is high ESR, you consider disease activity to be manifesting. When there is low ESR, you have to go for HLH or mass macrophage activation syndrome. So the main confusion might be this between these two, and the main clincher is your low ESR, where you have HLH. Why HLH? Again, hypofibrinogenemia occurs whenever fibrinogen decreases. Your RBCs cannot get stuck to each other, right? So RBCs need fibrin to get stuck to each other. When fibrin is not there, RBCs cannot get stuck to each other. They won't sediment. And when erythrocytes are not sedimenting, your erythrocyte sedimentation rate will be low. So this is your main classic, clincher between your disease activity versus your HLH. Then in enzyme replacement therapy, so again, this is a very tough question. I don't know where they got this from. This is not given in your Nelson. So obviously, you know that an enzyme replacement therapy is used in Gauchers, but it has been given that whenever there are anti-enzyme antibodies. So whenever you're giving any foreign substance to a child or a human, there are antibodies that develop against it. And there are a lot of cases where you have to give some kind of immunosuppression to prevent these antibodies from getting developed. A lot of times, especially in these enzyme replacement therapies, you add methotrexate. So methotrexate is given to decrease your anti-enzyme antibodies to be get formed. But in Gaucher's disease, this is not required because these antibodies may form, but that does not affect treatment efficacy. So this is given in your some research papers, etc., important papers, but again not mentioned specifically in your Nelson, so it's a little bit tough. But Gaucher disease is usually the correct answer here. And even if you look at weirdish questions, when you look at, right, so when you look at a lot very weird questions, they usually end up coming to a common answer. That is, for example, among these, which is the most common disease is Gaucher's, right? So sometimes you can use tricks like that to guess, especially if it's when +1 -1/4, you can use these tricks to kind of guess the correct answer. Craniopharyngioma, what is incorrect? Chemotherapy is not treatment of choice. Craniopharyngioma surgery is the treatment of choice. So that is clearly the wrong option here. Papillary CP subgroup is in adults. That is correct. So papillary CP is more common in adults, while adamantinomatous subgroup, adamantinomatous craniopharyngioma, is more common in your children. So that is, this is correct option. Then children with craniopharyngioma often present with endocrine abnormalities. Yes, that can occur because your hypothalamo-pituitary axis development, your axis can get infiltrated. That can cause endocrinological abnormalities. Distant metastasis is uncommon. That is also okay. Local recurrences are the ones that usually occur. But obviously, the main thing is your surgery is your treatment of choice and not your chemotherapy. A 25-month-old girl has come to the hospital. Stools are pale, foul-smelling, bulky, short stature. At 3 months, convulsions, neutropenia was there. Since then, she has had frequent otitis media, pneumonias, angular stomatitis, many dental caries, hemoglobin. So leukopenia, neutropenia, all of this is there. So there is some kind of bone marrow dysfunction. So among bone marrow dysfunction, and also there is steatorrhea, pancreatic insufficiency. So this combination, neutropenia is the clincher finding here. Plus there is pancreatic insufficiency. That is bulky, short stature, everything like something like cystic fibrosis related to pancreatic insufficiency. Fat is not getting absorbed. Along with that, there is neutropenia. So this is a classic Schwarzman diamond where you have pancreatic insufficiency and your bone marrow abnormalities. I'm sorry, this box seemed to have changed. The answer here is Schwarzman diamond. Again, you can kind of take a pick or pause it and look at this. Apple peel appearance, one-liner question. It is seen in 3B type of jejunal-ileal atresia. Not going further with this. Triangular face, again, very, very easy. Clincher triangular face is usually used for your Alagille syndrome. And I think JAG1 mutations are also seen. This is something that can be asked. So all of the other things like pointed chin, bulbous, straight nose with bulbous tip, all of these are also classic facial features of your Alagille syndrome. Echo shows peripheral pulmonary artery stenosis, which is usually the most common CHD that is seen. So liver involvement can occur, cholestasis can occur, peripheral PAS can occur, butterfly vertebra is something that is seen, posterior embryotoxon is your ocular anomalies that is seen in Alagille syndrome, all of that can occur. So NF1, optic glioma, optic nerve glioma. So it's one, right? Optic nerve glioma is usually one, while bilateral vestibular schwannomas is two. Just to remember, one is optic nerve glioma, two is your bilateral vestibular. Just to remember, you can remember like that. Then your final one, pretty straightforward, easy, low-grade fever, crampy abdominal pain. So one, abdominal pain, two, swollen knees, arthritis is there, and there is petechial rash. Kidney biopsy is also there, glomerulonephritis is also there. What more do you need? This is henoch purpura. I think we discussed this in our recent Elite also. We had I put the same question from this, so that's also there. So this is also an important differential that you should always remember. So these are your previous year questions that we have options as of your NEET SS 2023. I think we have compiled around, at least there would be 70 questions or so in 22 plus 23. So at least if these questions, these topics come, please don't get them wrong. Rest okay, it depends. It's very varied, to be very honest. It's a very varied paper that comes, but at least these questions, if you get them right, then you are, at least you're not doing a mistake that is pushing your rank, right? So yeah, thank you, that's it. Any questions, any doubts, you can always ask on our WhatsApp group, And yeah, even if you need any particular question that you might have missed noting down, or you need the PPT PDF, you can text me.